And it's now my pleasure to introduce John Malyon. John will be talking about normalization, normalizing, maintaining and regaining a normal state of anti-cancer surveillance. John.
Thank you. Good morning. Thank you. My name is John Malyon. I'm visiting from Calgary, Alberta, which, if you don't know where that is, it's an hour from Banff, right about where the prairies meet the Rocky Mountains. It's a beautiful country. I've been a computer programmer for about 30 years of one kind or another, and since about 2000, I've run a specialized internet search engine. 3 years ago, I was having my eyes checked for a new pair of glasses when an anomaly was found, which quickly led to me being diagnosed with UVL melanoma. And this was shocking, stunning, a bolt out of the blue, really. 1 minute I was in perfect health, possibly the best health of my life, and the next minute I had to deal with the fact that I was going to die someday. That was a significant portion of it, someday, ever. My parents are alive, my immediate family are all alive. I had never really been forced to deal with death as an existential truth at all. And suddenly, I was helpless, reduced to hoping for diagnostic tests to come out favorably, while contemplating my family continuing without me, their children, my descendants, and the lives that they would experience, civilizations rising and falling, and the world continuing to spin through space for billions of years after I died. I have a tendency to intellectualize things. These aren't exactly new thoughts, but when they're accompanied by a constant tension in your gut and kind of a tightness in your chest that makes it impossible to get that really cleansing breath, they feel like new thoughts. And these thoughts are really beyond my words to express. Now, after this weekend, it's apparent to me that my personal experience was a little different from both. So I got to go into that in more detail than I expected. First of all, the cancer presented as an iris melanoma, which has quite a good prognosis in general. And for that reason, I was given the option of either radiation therapy or surgery. I had the surgery, and the subsequent biopsy indicated there was ciliary body involvement. That raises the question of whether the tumor originated in the ciliary body and grew into the iris, or vice versa. Genetic testing on the cells puts me in the high-risk category for recurrence, which suggests that it began in the ciliary body, but I suppose that's not certain. I don't know if we can really know these things. Anyway, the surgery was quite challenging. The recovery period was about a month, with significant pain that I had to keep ahead of with painkillers. And in addition, I had a bleed in my eye the day after surgery. In fact, we'd just taken off the bandage, and I was doing an eye test, and miraculously, my vision was absolutely perfect and clear. And even while I was taking the eye test, I noticed a little streamlet of blood just kind of floating across my vision. And I guess it hit my retina shortly thereafter, and all of a sudden, boom, I couldn't make out anything at all with any clarity. By the time the bleed stopped, I could hardly make out light and dark. And the protocol in such cases is to stay still, sitting upright day and night, so that the blood can ever so gradually seep out of the eye. It was about 4 months before my vision really approached anything usable in that eye. That was bad. Boring, really. Spending most of the time in bed, but it was bad. And worse was the fact that the biopsy came back with the indication that there were viable tumor cells at the edge of the excised tissue. Maybe. I'm sure it's hard making this kind of determination with what's largely a blob of goo cut out of the eye. My surgeon thought that he had probably gotten it all, but he laid out my options, and I think he agreed the best action was to do plaque therapy as well as a backup. And here was the final gotcha. I couldn't have that therapy until my eye had completely healed from the surgery. So in the end, the tumor was definitively killed over 6 months after I began the journey, with me wondering the whole time what might be happening with those tumor cells at the edge. So that's the story of the year I turned 50. I want to stress that up until that point, my life had been completely blessed. After that time, my life has been completely blessed, but that year was not that great. Anyway, as we know, the primary is treatable, and we can do something about that. It's the risk of metastasis that's the real danger. I was advised that if the cancer spread, there were only a handful of treatments available, none of which, I was assured, would work. One oncologist worked particularly hard to make sure that I didn't have any false hopes on that score. And if Leah's here, she said, it's not the surgeon that we've both dealt with, so I don't want you to think that it's him. But there was a surgeon who made it his mission to stamp out false hope. And I've since discovered, by reading David Servan-Schreiber's book, that he really calls this false hopelessness. That there are a lot of things that can be done, and patients need to realize that. Anyway, the doctor's opinion was reinforced by my reading numerous scientific studies related to uveal melanoma, all of which seem to contain the same ominous phrase in the introduction: no effective treatment. So much so that if you could somehow patent the idea of there being no effective treatment for uveal melanoma, there'd be a very rich doctor out there somewhere. And furthermore, there was no possibility of a long-term remission 3 years ago. So not only that, but it primarily metastasized to the liver, where there would likely only be vague gastrointestinal symptoms for some period of time that would appear when the cancer was far advanced. So that was all just great. I brooded and obsessively self-monitored every little pain and gurgle in my stomach. And after about 6 months, the expected symptoms did show up. I semi-freaked out, got in for an ultrasound pretty quickly, and in retrospect, I'm sure that the pain and acidity were because I'd been giving myself an ulcer. That was the moment that I realized the absurdity of the situation that I was in, and I was able to let go of the whole thing. That was my accept the things that I cannot change moment. 2.5 years after that, and I'm still lucky enough to be NED, which is no evidence of disease, according to recent scans anyway, and I'm also ulcer-free. So that was also the moment when I took a step back and began questioning some of what I had been told about uveal melanoma. Are there in fact ways to alter the progress of the disease or change your risk profile? And beginning by looking at prognostic factors well established to be relevant in this type of cancer particularly, and then by looking at evidence from a wide variety of other cancers, what I learned leads me to believe that the answer is yes. There are variables that you can modify in your favor to potentially slow progression. And we don't have the slides set up, so hang on a sec here. First of all, I can proceed part way. Women have a significantly better prognosis than men. One study published in 2012 showed that their risk of death from uveal melanoma to be about half that of men. I'd known that they had a better prognosis, but half. That is, for a disease that's as implacable and relentless as uveal melanoma is supposedly to be. I can't believe I wrote that. That's a huge difference in outcome. Especially since hormone therapies and anti-hormone therapies are used so commonly in other diseases, including other types of cancer. Now, why is that true? Well, testosterone is known to generally depress the immune system, so perhaps that's a factor. Also, iron levels are correlated with cancer, and men are more likely to have excess iron than women. In any case, this is speculative, but this points to contributors to one's own risk profile that can potentially be changed. Okay. So, okay, we're up now, good. Another known prognostic factor is that younger patients have a significantly better prognosis than older patients. In a 2012 study, the overall 5-year rate of metastasis among young patients under 20, patients in their middle years, and seniors 60 plus was 8%, 11%, and 16%, respectively. So you can see that's a clear pattern of increasing risk for some reason or some combination of reasons. Well, a reasonable hypothesis would be that improving the biomarkers of aging could reduce your risk of metastasis. And what's the first thing that comes to mind when thinking about rejuvenating the body? Exercise. Perhaps engaging in vigorous exercise won't simply make you fitter and trimmer and happier, but it might actually reduce the odds of cancer progression. Now, we're not necessarily concerned with getting cancer, but progression after being diagnosed with cancer, which is what is relevant to most of the people in this room. So it turns out there's a lot of research on this. If we can find it. There we go. Exercise. In a 2013 meta-analysis, meta-analysis is a study of studies where researchers take a look at whatever studies are available in the literature. They try to find the ones that are the most rigorous and the most transparent, and the ones that can be directly compared and draw an overall conclusion. So these are usually quite good sources of information. In colorectal cancer, you can see that patients who participated in physical activity had the risk of death reduced by 26%. And high physical activity after diagnosis reduced the risk of death by 35%. So I think that you'll agree that those are significant numbers. And in 2011, breast cancer patients had a 24% reduced risk of recurrence and a 34% reduced risk of death if they participated in physical activity. And we're not talking about running triathlons here. We're just talking about the type of activity that puts an adaptive stress on your body in particular. So whatever you can do, you want to push that envelope. Now, what about in cutaneous melanoma? I put cutaneous in brackets because whenever I talk about melanoma today, I'm unfortunately going to be, by default, talking about cutaneous melanoma. And if I mean UVL, I will say that. It's not so well studied in melanoma, but in a 2001 study, you can see that exercising 5 to 7 days a week resulted in a 30% reduced risk of being diagnosed with melanoma. And we don't have any clinical data, or that I could find, but in a mouse model, you can see that exercise decreased the melanoma metastases and increased the ability of the immune system to kill melanoma cells. So this is the model I'm going to follow whenever I'm talking about any substance or any therapy in detail, is try to look at rigorous evidence of in other cancers in the overall field, and then try and bring it in as close as possible to UVL melanoma to at least suggest that there's a good reason to believe that it's going to be beneficial for us. Anyway, so right away we have what I would call overwhelming evidence that you can alter the risk of cancer progression and cancer mortality, even after being diagnosed. You're not helpless at the mercy of the universe. You can change your risk profile significantly. Now, here's another rejuvenating agent that may be highly relevant. Melatonin is a hormone produced by the pineal gland that synchronizes the body clock. Melatonin levels are known to decrease with age, as does the overall quality of a night's sleep, as some of you may know. There's lots of research on melatonin's value in fighting cancer, often as an adjuvant to conventional treatment. So melatonin, in a 2005 meta-analysis of 10 randomized clinical trials in patients being treated for solid tumors, melatonin use resulted in a 34% reduction in the risk of death in the first year. Again, I think we can agree that's a big number. In 2012 meta-analysis of 8 randomized clinical trials, melatonin improved the odds of a complete response or a partial response from 16% to 33%. And it improved the 1-year survival rate from 28 to 52%. And in yet another meta-analysis of, in that meta-analysis, by the way, I think that those studies were chosen because they all used the same dosage of melatonin, which was 20 milligrams a day, which is on the high side of what you would take for most purposes, but it's well known to be non-toxic. In yet another meta-analysis of 21 randomized clinical trials, melatonin use resulted in a 37% reduction in the risk of death in the first year. So these studies are all in good agreement, and you can see that there's a strong effect. I want to mention that all of the studies and some of the other specific facts that I quote, there's references that are posted online at the Ocular Melanoma Foundation forum. So you can get all the original studies there if you want to investigate further. Now, what about a UVL melanoma? Well, there's at least 3 studies I was able to find showing that melatonin inhibits the growth of UVL melanoma, but not normal cells. And in a study dating to 1991, patients with advanced melanoma were treated with melatonin alone. 6 of 40 patients experienced a partial response, and a further 6 experienced stable disease, which is no progression, no growth, for a clinical benefit of 30%. And melatonin was the only treatment required. And I really want to know what kind of a nut gave patients with advanced melanoma melatonin and no other treatment. But it worked. And 10 of these patients had an ocular primary. 1 had a partial response, 1 had stable disease. So those aren't very high numbers, but it's astonishing to me that this can happen with just melatonin and no other treatment. And I want to mention that in the second study, you may not find the details of the ocular melanoma in the abstract. You have to look at the full article to see that. So, if you don't see that information, it is there. So anyway, I take melatonin every night, and I can assure you the quality of my sleep has improved 1,000%. I sleep like a baby now. In fact, better than a baby. I sleep like a teenager now. I have one of those overactive minds, and for years I had experienced trouble getting off to sleep, waking up in the middle of the night and brooding over stuff, and really, that is all over. So, exercise and melatonin, 2 simple and powerful interventions. A third strategy to reduce one's biological age could be to reduce inflammation, which is associated with many chronic and age-related conditions. This can be achieved effectively through the use of NSAIDs such as aspirin and Celebrex, for example. Also indomethacin, ibuprofen, and naproxen. Aspirin. I think everybody knows, everybody in the medical community I think knows that there's a lot of research into aspirin as a cancer preventative. These numbers, a meta-analysis of 91, just 91 is a huge number of studies. Long-term daily use of NSAIDs and primarily aspirin in this study resulted in some rather astonishing reductions in the risk of cancer.
Do you have an average, what the average dose was in those studies? Or? They would either be low-dose aspirin or maybe a single aspirin a day. In my experience, that's the level that they're looking at.
I've seen claims that both are beneficial, but they're not looking at high-dose aspirin or anything. Okay, so post-diagnosis. In a 2013 study, aspirin use was found to be associated with a 33% lower risk of death from all causes. And in 2010, breast cancer patients, it was associated with reductions in risk of recurrence and the risk of death. And aspirin use at the highest frequency in this study, which was daily basically, resulted in a 43% lower risk of recurrence and a 64% lower risk of death from breast cancer. And in melanoma, in a 2011 study, use of aspirin for at least 5 years resulted, and aspirin does seem to have a better effect the longer you take it. So it's especially good if you're NED, so you have, some significant lead time, hopefully. But 49% reduced risk of being diagnosed with melanoma. So there's a strong indication that something good is going on there. Now, I apologize for all the data. I know it's too much to take in, and at a certain point, numbers turn into numbers. But I'm doing this to stress that this is real. This isn't fuzzy theorizing. It's not wishful thinking. It's a real effect that you can harness right now. And while we're on NSAIDs, let's take a look at Celebrex. One 2012 study showed the use of Celebrex for at least 2 years resulted in these reductions in the risk of being diagnosed with cancer. So again, I mean, it's ridiculous. I don't know how else to describe it. Post-diagnosis. In 2006 study of prostate cancer patients. Post-treatment, it's hard to clarify what they were studying exactly, but 36 out of 40 patients showed a benefit from the use of Celebrex in this case. And the PSA is I don't know what PSA stands for, but it's the marker of prostate-specific antigen, yes, which is, it uses a marker for prostate cancer progression. And in 2006, 2 studies published in the New England Journal of Medicine showed that patients who'd been surgically treated for colorectal adenomas, in those patients, it resulted in 33 and 36% reduction in the likelihood of their recurrence. So the type of numbers we're talking about, I mean, I believe that most cancer patients would walk through fire numbers. I mean, these are really, anything less than about 25%, it wouldn't even make the cut to be in here, because it's just, there's just so many studies that are available if you can do some serious research. And what about UVL melanoma? I love this. In 2006, doctors in British Columbia, Canada, thank you, treated 27 patients diagnosed with surgically incurable recurrent melanoma with Celebrex alone. Yet at the 200 milligram a day level, which is what anybody would take for a sore elbow. So, I mean, extremely low level of Celebrex. Tumor regressions were seen in 7 of 27 patients, including 2 complete regressions. And the only uveal melanoma patient who was in the study had multiple liver metastases up to 3 centimeters in diameter, and that person experienced a partial response with no tumor progression for 12 months. Impressive.
John?
Yes?
I have to ask if this person with Celebrex who had positive results was a male.
That I do not know, and I do not know if it was reported. I mean, you can, like I said, the reference is there. Again, in this particular one, I had to look up the full version, not just the abstract, to get this information, but I'm not even sure it was in the full version. So this example of uveal melanoma responding to Celebrex is what is called an N=1 result. You can't extrapolate any numbers, such as a response rate, from this. But there's one thing you can say definitively. It happened. It happened, and it can happen again. Now, I could name many, many more substances, as anybody who's read my posts know. But for now, let's just touch on green tea. a very simple thing that's reputed to have a wide range of beneficial effects. In 2010, a study of patients with chronic lymphocytic leukemia, 2/3 of patients being treated with green tea extract alone experienced an improvement in biomarkers of the disease. So that's a, well, you know what biomarkers are. I don't have the details offhand what they were, but it's a way of measuring what the cancer cells are actually up to. And in a 2004 study of patients with ovarian cancer, drinking at least 1 cup of green tea a day resulted in a 57% reduced risk of mortality versus non-drinkers. And in UVL melanoma, EGCG is the active ingredient we're probably concerned with. And in a 2013 study, EGCG inhibited cell proliferation in a variety of UVL melanoma cell lines, suppressing colony formation and inhibiting migration. So this is where we stand. The research is haphazard, by which I mean which substances are treated against which types of cancer is kind of random, and it's enormously incomplete. And not that much has been done in uveal melanoma specifically. But if I achieve nothing else today, I want to convince you that these results are real and significant, and offering some degree of hope to everybody in this room today. Now, the last thing I want to touch on is moving beyond seeing these therapies individually and trying to make a synthesis of what all of this might mean. Well, for one thing, conventional cancer treatments, radiation and chemotherapy, and I'm not talking about, say, Yervoy here, but conventional cancer treatments are generally toxic and debilitating. They cause collateral damage to local healthy tissue and throughout the body, which can paradoxically create more favorable conditions for cancer growth, even while killing off large numbers of cancer cells. On the other hand, the treatments I've mentioned here, exercise, melatonin, aspirin, Celebrex, green tea, don't cause this type of damage. In fact, they're overwhelmingly beneficial, healthful, in helping us to fight off other diseases besides just cancer. Now, this is true of a great variety of phytonutrients and other anti-cancer substances. They generally promote healthy functioning of the body and even promote healthy functioning of cancer cells, by which I mean encouraging them to behave more like normal, healthy cells. And I'll present a bit of evidence of this in the breakout session later. Now, I haven't seen it described in exactly this way, but this is the process I call normalizing. It's not in opposition to traditional cancer treatment, but it's different from traditional cancer treatment. Essentially, it's based on the idea that the human body has numerous checks in place to prevent damaged cells from proliferating out of control. Cancer cells are vulnerable to being killed or disabled by all of these. The vast majority of potential cells will fall victim to one of these controls and will never form a dangerous tumor. So cancer cells or precancerous cells to all of these types of controls. Okay, the first one, apoptosis, may be the best known one, but there's all of these different checks that can have different results. They can result in cell death, or they can result in the cell remaining dormant. And the cells that don't die, the ones that stay alive, are severely constrained by all these controls, and they have to make adaptations if they're going to survive. And these adaptations means the cell must act what I would call dysfunctionally, or induce external dysfunction in your body. Normalizing is the idea that correcting those dysfunctions anywhere and everywhere possible can inhibit cancer progression. Now, here are some of the major targets in a normalizing strategy. These are the goals we would ideally want to achieve. Okay? All of these things, I don't think I have time to really go through everything in detail, but you can see that all of these are contributors to cancer progression in various ways. I think most of them would be familiar. And we get to this point by increasing healthy, normal function, signaling hormones and so on. For example, by exercise. One might say, now it doesn't really matter except for the end result, but one might say that vigorous exercise produces a rush of healthy signals, chemicals, oxygenation, healthy gene expression, improved immune function, all these things. Now we also get to this point on the screen by shutting down unhealthy, abnormal function. For example, by reducing inflammation. And there are strategies, natural substances, cancer drugs, off-label drugs, to hit all of these processes in multiple ways. So in every way possible, we want to flood the body with healthy forces and block or at least drown out the unhealthy forces. Systematically, not just hitting one target, but hitting every target that we can identify. Now, doing this should increase the body's resistance to cancer and slow down or even reverse cancer progression. Now, I've written some boilerplate disclaimers here, which is just blah, blah about how, there's no guarantees and so on. We're not talking about a cure, we're just talking about improving outcomes. But it's really, I'm not sure I even really believe that. I think that this is a theory that is extremely significant. And it's not my personal theory. I mean, it's just a lot of other research that's been done by hundreds and thousands of other people. But in terms of normalizing in particular, scientific theories can be stated as either a weak theory or a strong theory. And a weak theory is, you'll always see these patterns emerge. That if you can generally keep all these forces in check, that you'll generally have good outcomes and so on. A strong theory is actually predictive. And I would say, I'd like to eventually be able to express this as a strong theory, so that if you can identify dysfunctional targets, all of the broad major targets that are relevant to cancer, and if you can measure or monitor the ongoing status of those targets, and if you can successfully target those, or if you can successfully reduce those targets to a reasonable degree. So if you can keep them in reasonable check, not 100%, but if you can manage to maintain a normal state of health, then the cancer should be unable to progress at all. And this is, in some cases, if you look at epigenetics, for example, this may even be true just in terms of epigenetics alone. If you can completely shut down epigenetic adaptations, that in itself might be sufficient. Be very hard, but it might be sufficient to completely stop cancer progression. Doesn't mean that the cancer cells would die. It just means that they would be completely constrained and completely prevented from progressing to a more dangerous state. So that's all I've got for this section. And in the breakout session, I'm going to cover a few more things in detail, a few more interventions that should be considered perhaps. And I'd also like to hopefully have time to get into the immune system and with special regard to Yervoy. Why Yervoy works, and in my opinion, the more important question, why it doesn't work. Why it only works in perhaps 28% of people, according to the slides yesterday. And perhaps there's ways to improve on that, or at least to investigate new directions to find ways to improve on that. So that's it for now. Is there questions? Probably. Yes, at the back.
Is Celebrex, is that over the counter or doctor prescribed?
I have a prescription. I take Celebrex and I get it by prescription. I didn't get it from my oncologist. I actually went to my GP and presented him with some evidence, and he was quite happy to prescribe it for me. He thought it was relatively harmless at lower doses, and he's very supportive. Yes?
Take Celebrex, do you still do the aspirin, or is...
That's a very good question. A lot of people, a lot of researchers refer to the NSAIDs as COX-2 inhibitors, and everything that's a COX-2 inhibitor is kind of anti-cancer. But if you look at the research in detail, it looks like all of these things have a lot of COX-2 independent anti-cancer functions. I personally, I'm not going to presume to say anybody what anybody else should do, but I personally take both. Yes?
Dosage for something.
Well, normal dosage is 200 milligrams. I'm taking 400. I looked up the effects, the studies of toxicity in Celebrex, and at 400 milligrams, the toxicity is very low. It's maybe over 5 years. There's a slight risk of cardiac events, you might say. I think it's in the range of about 5% or something like that. So it's something to consider. But it's quite low based on the risk-reward profile that I've made up for myself.
The amount of melatonin you mentioned.
Pardon me?
The amount of melatonin you take every day.
Oh, melatonin? Oh, 10 milligrams is what I take. Yeah.
Is there any difference melatonin if you spray that one in the night or take it all at night?
Oh, you should take it all at night because it. Oh, you mean throughout the night, the delayed release?
I usually split between your breakfast pill and not bedtime pill.
Melatonin?
Melatonin will take you only at night.
Yeah.
If they increase the dosage, we pay it spread through the day.
I'm sorry, are you talking about melatonin though?
Melatonin.
Yeah, I would just take it at night, either in a delayed release or just all at once, sublingual. Yeah.
And I have to say for anyone who's on Yervoy melatonin, and Yervoy can shut down your pituitary gland, so melatonin is contraindicated if you're on cortisol. Just be careful.
Okay, that's.
Ask your endocrinologist, ask your doctor.
Yeah, that's good to know. And I would
There are
absolutely.
should be contraindications.
Yeah, I would absolutely say that all of this should be done in conjunction with your doctor and also in conjunction with conventional treatment. I absolutely wouldn't, were I to progress to the next stage, I would be first in line to get, whatever conventional treatments were available. So I'm not against that at all. Yeah.
You talked about the supplements, you spoke about exercise and all that.
Yes.
But what about diet? I've read an awful lot about low carb, no sugar, all this, and try to keep to that.
That's a very controversial topic. We were talking about that last night, and it's hard because I've seen people recommend low protein diets, I've seen people recommend low carb diets, and I've seen people recommend low fat diets. So if you don't eat anything, you're all set. Beyond that, I'm personally kind of a low carb person, but I don't take it to extremes.
What about the green tea extract?
Yes.
Isn't that available in a tablet form, and if so?
Yeah, that's right. You can drink green tea, or there's different types of extracts. I actually do take it as an extract, with 3 meals a day. So I think that's good, and just try and get a good quality one. And you can also get one. Originally found one that was something like 80% EGCG, which is really potent, really powerful. But I think that might be getting a little too pharmaceutical. I think you want one that's got a wider range of all of the catechins, all the phytonutrients that are in green tea. Don't focus too much on any one in particular, because they all synergize together and they all help each other get absorbed and act. Any others? Yeah.
If you're going through treatments, that aspirin is, of course, not a good thing.
Yes, of course.
You're going to have to be off of that for a week or, 10 days before getting any kind of procedure done.
Yes, absolutely. Well, that's true, and I would, be totally in favor of, trying a multiplicity of approaches at the same time. That's really the direction I would like to go, but you have to look at them all and see if they interact with each other or interact with anything else that you're doing. So all these things require some personal research. I couldn't, presume to tell anybody to do something without that.
We need to.
Okay, we're running out of time.
Well, thank you very much.